Welcome, everybody. My name is Vicky Hannah. I'm going to be delivering this unit in CHCCCS014, one of our short course AOD units, provide brief interventions. So this particular unit is really a crisis response. You may be the first responder when we're dealing with our clients. They're usually in a fairly heightened state. And so this particular unit will go beautifully beside the other units that we've done as your practitioner skills. So this is actually quite a big unit. The AOD is very complex. Those of you who are working in the sector already or would like to work in the sector will often find that there's coexisting needs, a dual diagnosis with our clients, so very complex. So even at the initial intake and assessment, it requires these underpinning skills, your particular interviewing style. We have both the theory, your key learnings, and your practitioner skills, your role plays, which form your assessment to be competent in this unit. So let's get started. And before we do, I'd like to do acknowledgement to country. So in the spirit of reconciliation, Hayter Institute of Education acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We recognise Aboriginal and Torres Strait Islander people as the first inhabitants of this nation and the traditional custodians of the land on which we work, live and study. We express our gratitude for the sharing of this land, our sorrow for the personal, spiritual and cultural costs of that sharing, and hope that we may move forward together in harmony and in the spirit of healing. We pay our respect to all First Nation people and acknowledge elders past, present and emerging. So person-centred or self-centred, so the client is collaborating in their space with us. So this is about the client's own goals and their contribution to creating a document as we walk beside them and facilitate that process. So by the end of this session, we'll have unpacked supportive and evidence-based practices, positive communication, your micro skills, and the role and the scope of what a brief intervention is. It does say it in the wording. However, let's have a look at what we must put into a brief intervention within this particular target group. So there's a video there to watch on drug addiction and person-centred. I want you to watch that recording and reflect. So if you're up to this slide, you have watched that one. And so as part of our introduction, Australia is quite a drinking culture, and it has been since the very first fleet came to Australia and colonised this country as part of the British Empire. So almost half of Australian adults will have ill mental health in their lifetime. AOD has a big toll on mental health. And then the main drugs of concern are alcohol, amphetamines, cannabis, and heroin. So more people die from alcohol-related diseases than any other disease in Australia. So how do we, as a non-clinical support worker, work in this space? We provide interventions, we do support around mental health and well-being, we meet people when they are the most vulnerable, and we do research that's evidence-based practice, and we apply that as we're doing our work. So the good news about this is it's a process. It is a skill that you can hone. It is not something where you have to dig deep and think, oh gosh, I don't know what to say. The practitioner skills are about getting our clients to say things so that we can create a plan, a treatment plan and a support plan, individualized for them. So it's person-centered, to be able to assist them with what they present with, and their priority of needs at the moment. So the only thing that changes for us will be the client, the person's story and the scenario. Our practitioner skills are applied each and every situation. Now, we do that with healthy professional boundaries, with micro skills, a whole range of communication skills. And we do that inside our protocols that we have in the workplace, which are underpinning for the legislation and the human rights that all of our clients have when we're working as a community sector worker. So you may have your own view, your worldview around addictions. You may have a lived experience. You may have someone near and dear to you who has experienced that, or you may be motivated to be working in this space. So your why can also influence how your style is, which is great. Inside a guideline, there is so much room for different types of practitioners in this space. And it would be reasonable to say that we don't fit every client. And then not every client will be a good fit for our style as well. So let's have a look at what some of these tools are and break them down. So supportive and evidence-based practice means that we don't have to come up with an idea or search Dr. Google. There are a whole range of proven evidence-based practice. So EBP is the acronym often you'll see pop up in our readings. It means that it has been proven, that it has been applied and it's been tested as coming from our clients, that it has had progress, improvement, or recovery. So we consider the client's situation, their unique individual needs. That could be cultural, that could be developmental, that could be availability, it could be their capacity, it could be what is their mental health when they present, what is currently happening to them and what has happened to them. It could be our own expertise and our own experience. There is lots of room for people who have a lived experience in this sector. And then there's the research and the evidence to support good practice and standards of practice that we can consistently apply for our services across Australia. So there's a short brief video there. It's based around young people. However, I try not to put that age around our clients in when I'm dealing with coexisting needs, simply because that is the thing that presents, that's the priority. So yes, I might be dealing with a 34 or a 39 or a 58-year-old person who is an alcoholic. However, I know that all addiction is at the root cause. There is some trauma. And trauma is not always a single event. It can often be over a long period of time, and it's the body's inability to be able to process what's happened. So often someone will be stunted at the age of 14 or 15 or 16, even though they present in an adult body. Their ability or their coping skills may still be ambiguous, like deeply frozen in a particular year in their life where things changed or shifted for them. And they may have gone forward and taken on the appearance of everything being okay. However, often I find that I'm working with a 14-year-old level of problem-solving ability, and it may present in an adult body. So I want you to always consider the inner child, the healing that we may have to actually go quite a way back if we're sitting in case management. This unit, though, is brief interventions, the immediate presentation of the priorities that our client is coming to us for. So we look at safe, effective, connected, person-centered community services. When we're working with young people, it's safe, supported, and supervised. because often they'll be under the age of 18. So that video is around how a young person may deal with it, but this can be their first introduction to substances or excess of both illicit and prescription medication as well. So we look at what are the supports that wrap around client and family and partnerships, so significant others. However, often by the time someone comes to us, those things have disintegrated. Those bridges have been left with lots of repair work that needs to be done, where the family will try and struggle themselves and cope. This isn't something that happens overnight. By the time our clients access our supports and services, they are usually well down that path of addiction or their maladaptive coping mechanisms. So if they are still functioning, and I don't refer to highly functioning because you can't be a highly functioning addict, you are an addict and you may still be functioning. So you may have support in the workplace, however you may have lost that stream of income, depending on our client. What is best practice? And that will be evidence-based. What is the risk assessment and how will we manage that risk? And what's the leadership and culture around the organisation that you work with or you would like to work with? And what are your peer supports like when you're doing this front-facing work? So at HADA, every single trainer is a sector worker. So that's our day job because we're a night RTO. So this is our day, the leadership and culture of our trainers when we come in and work as a team, our leadership and culture in the organisations that we work with during the day, because we are all practitioners with currency in quite a broad area all around Australia. Our trainers are based, which of course is our head office, but we bring with that a range of practitioner skills and then service models that we work under. Alcohol and other drugs or addiction, let's not rule out things like caffeine, cigarettes, nicotine, vaping, any other addictive type behaviours that are creating some level of distress in our clients' world or the people who care for them or in the workplace as well. And then how can we support them and manage any of those risks or potential harm to the point where we can provide a brief intervention and an initial intake assessment plan. So here's an assessment reflection point. So research and identify the mental health framework that is applicable to your state or territory. So what I want you to do is a little bit of research. I like everyone to go local as well, because if you're wanting to work in the sector, what is available close by? Is there a residential rehabilitation centre accessible to your clients? If you're going to be listening to what their needs are, if accommodation is an issue, if they are at that decision-making process, then perhaps you'll need to find a residential program which will have a clinical detox and then a residential program under a service framework, an evidence-based model, which could last for 3 months or 6 months in a residential support, specifically around addictive behaviours. So have a look at what is the mental health framework and research this for your state or territory. And when you get to your assessment, please put in based in New South Wales or based in Victoria. Here are my findings. I'm based in Queensland, so I would go to that, and I would also go to perhaps a peak body as well. I like to put in a couple, the community connection, but also the government framework as well. When we talk about politics in services, know that the reference there is about the government of the day deciding to put public funds or taxpayer dollars into services. When they do that, those service providers get the funding and they employ workers. So we can never separate what is the most important presenting issue and the costs around how this has an impact and if something is in the public interest. So we can identify a need or an unmet need in our community and significant gaps in that. It is the government of the day that makes the decision of whether they will invest that and if the ones that they have invested are effective and efficient and the best use of public funds. So they have a say also in the level of workers. So the unit that you're doing around brief interventions is one of the essential key units and skills to be able to get an entry level into the sector. You may already be working in the sector, and this will give you an Australian recognised unit, recognised Australian quality framework standard, which your sector, anything in AOD and mental health, youth work and community services would recognise, because oftentimes we will do brief interventions because we work with some of the most vulnerable members of our community. So person-centred and client-led, so that kind of, it says it all, doesn't it? The person in the centre is the young person or the client, regardless of their age and their demographic. And then the client, that person, will contribute, and we can't build a plan without the client. The only person who is the expert on our client, of course, is the client. So we seek to understand the individual, and we do that using micro skills, our intentional interviewing questions. We have motivational interviewing questions to lead people towards a solution, options in front of them, informed decision making, that we demonstrate our respect for the individual, that we are inclusive, and the services that we recommend are accessible. So that's physically accessible, mentally accessible, psychologically safe for them to be having this storytelling moment with us, and that we come at this with a sensitive approach, and we focus on positive outcomes, so solution focused. These are skills, and we have some videos for you on some of those practitioner skills, your micro skills, which we will assess when we get to our role play component. So person-centeredness is about personhood, being privileged about anything else. So in other words, when people tell their story, they tell the story of who they are and what they stand for, but also the backstory of how things got to this. Professor Nicholas Proctor. Gabor Mate will say, and what else? He will go there. He will say, all trauma is linked to addiction. All trauma is linked to anxiety. All trauma is linked. So we need to know what happened to you, not at the first session, but if you can establish a relationship and build trust with your clients, and they feel that you're a person that they can talk to, not be talked to. So about 40% of our work is listening, active listening and paraphrasing to know that we got that right. But it's about 60% of getting our clients to communicate and share. And that may not happen at the initial, but in a brief intervention, there's some essential risk management things that we must measure. And I want to lead you into that. So there's a podcast to listen to here. Listen to this regards strength-based approach for your line of work. So just know that when you copy and paste a link like this, that you may need to go and put that in your own search engine just to be able to help you move past that. So I don't record any of the videos or the podcasts when I'm actually recording with you. Two reasons. One, I want you to be able to look at that resource in your own time and reflect on that and not rush you. And the other reason is that we must be really mindful of when we use evidence-based resources, that we have permission to use them and copyright. And when you're putting them into your answers, that you will reference where you got your evidence from. So we must always acknowledge the source of the information that we put into our work. And also, once we're qualified, to be able to put that into our practice so that we can feel confident that we're working with a sector standard. So recognise and lead with your client's strengths. The person is viewed as resourceful and resilient, that there are things that they can do for themselves. I would never do for a client that they can do for themselves. However, I would check, is that something that you need help with? Because on a good day, they can, but maybe on a time where things are all just overwhelming, they may not. So I need to check in and find out, empower or give agency for people to build their strengths and acknowledge that, and then communicate with the person on progress and keep reviewing that. Now, look, as a worker, I look at that picture and I go, you know what, I would never touch a client. What do you see when you see that? So our professional boundaries are very important, and we will always work inside those guidelines. So it's a picture, but still it kind of says something to me. So that'll be based around culture. I know when I was living and working in another country, the population was larger than where I live now. So people's personal zone came in a little tighter. So have a think about the culture where touch is connection for some people, but know that when we're in that space that we would have a professional boundary that we would work with, and our communication is our body language as well as our verbal and our non-verbal, of course. So positive communication and compassionate inquiry. So here we have unconditional positive regard. You may see UPR, you may see an assessor just say, I've observed the learner, you, when you present your role play, apply your micro skills. This is what we mean. So you're working with empathy, you're working within the rights of your client, you're respectful of their rights to their own feelings, thoughts and ideas. There's no right or wrong. This is about dignity, your duty of care around their safety, that the person's own values and the belief that they are capable. So for you, this is a toolbox tip around a micro skill that we look for in our observation checklist as an assessor. I'll take you there at the end of this session. What do we mark you on when you jump in? Know, though, that there's a lot of extra resources out there. This is where you practice. It is where the rubber hits the road, though. As far as the theory, we can have that knowledge, but the practitioner skill, we need to be able to apply it, because your qualification in this unit says that I have the knowledge and the skills and the ability to apply that in this particular area of brief interventions. So just let me pause here before we move in. Just want to get my screen right. Sorry about that. I think it's playing up a little. We're human too, so don't panic when you get to that stage when you're actually working with your role plays. Step into that space and be real for our clients as much as ourselves. Just a little bit of tech work here. Okay, so just a little bit of a tech, and I've just taken that time to see how we go, but we've slightly changed our screen, so I hope that's okay for you at the moment. So moving on from unconditional and positive regard, one of our values-based practitioner skills, we then move into our positive communication. So that's our motivational interviewing, all our open-ended questions on person first and non-judgmental language, and then our prizing the person, how they feel about themselves through observation, and then building internal positivity, professional recognizing those internal feelings and acknowledging, keeping that in a safe way. We've got a couple of videos for you to be able to have a look at to hone those skills as well. So we use active listening, hearing what the other person is saying, and then maybe saying it back to them, not parroting, but paraphrasing. That sounds hard. Like it sounds like you've been going through a lot. And if what they have shared with you, they're waiting to hear some validation that they are believed and that it is safe to be able to share that story with you. What is a brief intervention? It is the screening, the gaining information and putting an action plan into place with our client. When is it applied? Those who have not sought support themselves, so that might be that someone has made that decision for them. It could be their GP, I'm referring you over. It could be the police who attended a matter, maybe a disturbance. It could also be members of the family, significant others that want someone, really genuinely want someone to get help. And that those who have been identified as a risk, harm to self or others, and also part of the public health strategy under an involuntary order. A brief intervention may include all of those things, not just one. So some further reading is I want you to explore the National Preventative Health Strategy, especially the AOD pages for this particular unit, and then look up pages 64 to 67. That's part of your research, and you may need to refer to that in your assessment work. So a brief intervention, what's our role as non-clinical workers? It is to inform people about what those consequential thinking might be or the implications of their dependency through their addiction. It could be about hospital and specialist clinics that you may be referring to, or walking beside your client to access those services. They are usually one-on-one sessions, and they're utilised for a new patient or a client. So in the non-clinical area, we don't do any diagnosis, no prescriptions, but in a clinical area, they will. Often, if you're a community sector AOD worker, you will be working very closely with your clinicians. So visiting GP, visiting psychologist, visiting mental health experts, visiting practitioners around that. And then, of course, you will, once they leave, you will be looking after that individualised care plan, that therapeutic treatment plan that you and your client have created together, and you move at the speed that the client's recovery can take place. So it depends on where our client is up to as well. So the reflection here is what might be a barrier that could exist regarding a brief intervention. What would be getting in the way? And for some people, even getting help can be re-traumatizing for them. It can bring up anger, resistance, mostly fear-based. Let's have a look at what some might be. So it could be a lack of resources in the local area previously, but now they're in front of you. You'll be able to help them find what's available locally. And in the meantime, when they're not with you and not with their clinician, the lack of time within the workload for you being able to spend that time with them, because it's a brief intervention, and that relationship doesn't last long. It is intake, assessment, risk management, refer. So it could be the client's lack of confidence in themselves, or for you as a worker, some clients, they are very complex and we need to bring in other people. And then for some clients, they've had quite a history where they've been accessing services and supports, and they know their way around this. For some, it is the first time that they've ever sought help, and it may not be their decision. It could be that it's actually mandated, meaning that they've been told to. So we get a lot of referrals from probation parole when we're working in this space. So there can be difficulty, discomfort, fear, uncertainty. I'm not quite sure how this is going to go and where it will end up. So assessing the intervention need, so the priority of need. So we'll look at the strengths and then what are the behaviours and issues of concern. We'll support any changes, because on the other side of that change could be improved health, improved relationship, improved employability, improved balance, and a healthier, more regulated space for our clients. And then the health and well-being, asserting awareness, and that is informed decision making. So the information will often come from us. It needs to be current, it needs to be accessible, it needs to be equitable, so our clients are eligible for that. We need to check all of that out before we do referrals on. What we don't want to do is send our client to a space where it's got a huge wait list. So this is our background work. What's available locally? What's available currently? What eligibility does our client need to be able to have that support and service in that referral? And your relationships with those other referral points as stakeholders, other service providers, that's a space where we work well with our peers, and we need to build those skills around seamless referral pathways. And that could be others referring to you for the community support, the non-clinical care, and it could also be you referring out to others who you've decided with your client to put wraparound support services in their individual plan. So we will set some brief goals based on their interests, history, and experience. If something hasn't gone well in the past, then we need to be able to bring some of that out. What are the skills and their capacity now? Where are they strong? Because we want to work to their strengths. What networks and supports are there? The culture that they're living in, are they heading straight back into an environment that's very triggering for their addiction? Are we listening? And are we building rapport, which is, are we making a connection, engagement, and establishing, I guess, a professional relationship where we can create trust and safe storytelling? Keep in mind, it's quite difficult for every client to talk about their story. We are re-injuring, and we don't want to leave or have our clients leave us in that session with open wounds. So we need to manage this effectively. So some resources, the organisation that you're with has a good professional relationship, and so will you. That you're working with current information, you to have an understanding around what is drug use. Part of this short course is around the unit AOD 001, where we speak about the different types of drugs and the impact and effect that has, and that they are clinically sound questionnaires where we're doing all of the risk management. We're looking at the physical, we're looking at the mental health and well-being as well. We're looking at the history, some health history, and then who are their contacts? Who do they go to for that support? And if they haven't, we'll identify what those gaps are and put that into our plan. So some reflection here and some research for you for your assessment. Consider the type of information that should be gathered from the person, when and for how long. So intake and assessment includes your client's name, their contact number, their current location, who are their next of kin, or who would we call if something was wrong. Now, keep in mind that not everybody will want their name written down, so we can assign a client ID number, and everybody under the Privacy Act of 1988 has the right to have their information kept private and confidential and secured. So this could, someone accessing supports could adversely affect their reputation, because we already know that addiction has no boundary as far as age or wealth or standing in community. It isn't a particular group. There's a lot of secrets around addiction. A lot of secrets are kept to protect people around their addiction, often referred to as enabling, but people are unskilled and they're worried about the consequences, so you can understand why they may do that. So now they're seeking help. We reflect upon what information can we gather and for how long. If we do a referral, it's specific, not an open-ended, I can talk to anybody anytime about you. It is, I will talk to these two people because we've decided that these might be good supports, and I'll do that right up until they take that referral over. And then that will be the end of that referral. And if it's a good fit for you, then when you pop back and see me next time, or can I follow up and check how that went for you, then we'll decide, if that's a good fit, or we'll refer again. Always letting our clients know that they have the choice in this. So it's not uncommon for a client to say, look, I know you made the appointment, but I didn't go. I just couldn't walk in through the door. Actually parked out the front, sat outside. Not uncommon at all. So that anxiety, that fear, can be very strong. So oftentimes, if our role says that we can walk beside our clients and access these referral points, then we may walk in through the door with them to their GP office and wait. Sometimes we can even go in. Your GP understands that we are working collaboratively, and this is a wraparound support, because the GP knows that they are one part and that the community service workers actually fill quite a large part of helping someone not be admitted into hospital. That's all that prevention, early intervention space once someone has access supports. So the gathering of information, tell me about what's happening for you at home, what's your living conditions, do you have support? And if not, that's a gap and we can work with that. The education and employment history, are they currently working? Is this impacting it? Would they like to return to work? Relationships and sexuality, what support is available for them? And then preferred activities, strength and interest based. So that will be a holistic approach. It might be mindfulness, art therapy, relaxation. It could be walking. It could be financial well-being, where you're working with someone on their budget, securing their housing stability. There's lots of areas that we will work with as a community sector worker, even though they came in through the door around AOD. So we'll gather information, past and present, and to do that, that will get us into that space of hope and healing into the future. And then what are some barriers? Are they speed bumps, something that we just need to slow down a little and get over the other side of? Or are they deal breakers? Are they things where we really have to stop and have a complete rethink and make some different choices? Often when we're at that point, it'll be that we're before the courts, that the matter is actually being in the justice system, or it could be that family have given ultimatums. They will be the deal breaker ones. And the deal breaker means that there's some decisions to be made. We don't yet know whether our client is in that decision-making phase, if they're thinking about it, or if they don't believe that it is a problem, that other people have a problem with it, but they're okay. So we need to be doing all these assessments in our brief intervention. So I said general health and nutrition like, and that might be why someone justifies or is in complete denial. And then what is their current use, their drug of choice? That could be alcohol, it could be other addictive type substances. And if it's drinks, how many drinks a day? What are you drinking? There's a difference between drinking beer and, of course, drinking spirits. And then we work with glasses, or we can work with litres, depending on our client. So there's a video there for you to watch on identifying the alcohol content. But oftentimes, once we get a physical check and a blood work done, and iron deficiency, we can start working on how to do our community work, whereas our GP will be looking at the physical health. So reflecting on the practitioner skills from the previous video, you'll be working with a particular this one here is your risk assessment, assisted suicide intervention, but it's light. So it is not that they're thinking of it, but they may be at risk of if we don't get in and do those wraparound supports. So reflect on the practitioner skills, and then reflect on which one of those actually aligned with you, based on those tools, which seem to be a better fit for you as a practitioner, because you may have a particular style that you want to work to, and we can, inside the guidelines and the policies and procedures of our organisation, we absolutely can apply our approach. And so there's no cookie cutter in this. Your engagement, your ability to connect with people will come from you. And this is about your information, your knowledge, and your micro skills, but your why do you want to work in this sector? Your clients will sense that quickly, and your energy. It may be that this is an area that you're really interested in, and you want to hone that skill, or it might be essential for you to have that because of the work you want to get into. Mental health, homelessness, and AOD are vulnerable people, and that may be a requirement for you to be able to get in and do some of that work. So brief interventions crosses every sector, every community sector. Often you are the first person that person will be doing their intake and assessment with. So what style best fits with you? So where are they in their decision-making process? Pre-contemplation means not ready to make a decision, or actually not even thinking there's a decision to be made. Contemplation is like, I'm aware and I'm thinking about it, but I need some things to think about. What does it mean? What am I saying I'll do? The determination or the preparation is getting that information and forming a plan. And then we implement that plan. That's our action point. And then we do the maintenance to keep that plan going. And we may have a slip or a relapse, which means that it might mean that we go from this part back to maintenance. Okay, that's fine. I just stop doing that. I need to keep doing that. It might mean that I set unrealistic expectations on myself, and it wasn't realistic. So I'll go back to my action point, the number of times that I'm going to meditate or go to yoga or do Tai Chi or go walking. And then it might mean that I actually have to go back on working with some information that isn't a good fit for me. Our role is to facilitate that plan and around the decision making, because people will start to talk themselves out of it because they don't know what's on the other side. That's fine. We just circle back to it. So let's just revisit this plan. There's something that's not quite right at the moment, and we need to zero in on what that would be. On average, it takes 7 times for somebody to leave a domestic family violence relationship. On average, it's 7 times for somebody to attempt to go to rehab and work towards their recovery and stay with that recovery. So that's not everybody, but it's the 7th time that seems to work. So they are reprogramming and they're going back. I don't know if I want to. I don't think I'm ready. I'm going to go right back to step 1. I haven't got a problem, everyone else. It's not working. It's not happening quick enough. There's a lot of things. It's part of the addictive mind to sabotage recovery. So the stages of change are around what are the elements? What do they think of when they're in pre-contemplation, contemplation, and then the action points and the maintenance of those actions. So you will be asked what are the questions and the numbers in your assessment around that, around the decision-making process. That will be an assessment question for you. So there's a video there for you to watch on the stages of change, and just reflect upon that as well. So I want you to, just in assessment, have a look at the readiness to change questionnaire. So that's actually a really good one. They're tools, evidence-based tools for us to be able to refer to. So this is the end of this brief session. I'm jumping straight into another one. But at this point, I've actually covered 2 big areas. What it is when we first meet our client, how are we when we're sitting in this space, what's our role for a brief intervention, what tools do we have to be able to work with, what's our reflection about the approach that we're going to have with our clients and develop those micro skills, and how are we going to work in that space where we can be part of once that client is in that contemplation stage, whether they're motivated towards something or whether they're motivated away from something, and that might be the reason they came in through the door. So we'll just take a brief break here. I want you to stretch and hydrate, and we'll jump straight into our 3rd and our 4th sessions, and then I'll show you some assessments as well. Okay, so this is our final slide that I wanted to do on CHCCCS014. These resources will come out to you as well. You'll have your learner's guide and you'll have access to your student portal, where you'll have task 1, task 2, task 3, and there'll be written assessments like a quiz you might start with, and then you'll have maybe a report, maybe a case study, maybe a role play to do. So we'll have a look at that at the end of this. But I wanted to wrap up with the final part of this, which is around brief interventions. Let's get started. So referrals and document resources. this is falling into our legal and ethical framework. Unfortunately, sometimes our clients are before the court system, and the courts may, or legal aid may want copies of the file notes. So we need to keep accurate records and documents around our clients, because we are the keepers of health records. So if it's a young person, you must keep your records for 27 years, because a young person may have something that has happened for them or to them when they're quite young, and they give young people time to be able to put that into place as they become an adult, because of the developmental stages of when trauma may impact a young person. Then we make sure that they've got that fairness and equity in that space. For adults, you hold on to that according to your protocols, your policies and procedures, but it is best practice that we store and secure all documentation, and that our notes reflect factual record of the events that happened. So by the end of this session, we'll have discussed opportunities for referrals and support, and then document resources and the legal requirements around that. So what's relapse, lapse and maintenance? So a slip, off the wagon, it might have other terms as well, where it can be frustrating for those who aren't trained. Why don't they just? It's not that simple. It definitely is not, because we're talking mental health, and we're also talking a physical, addictive chemical that's in somebody's body, where even stopping can be quite dangerous if it's not managed in a clinical way. So a relapse is when a person stops the maintenance side of their goals and intervention. Oftentimes it could be part of that plan is to be on medication, and they start to feel better, and it's, I don't need this anymore, I'm all fixed, this is great. And so it's not always a resistance. Sometimes it's like, oh, I've got it, I'm feeling so much better, I'm putting some things in place. However, by stopping too soon, it could mean that they will relapse. Oftentimes, it's taken years for that addictive pattern, that habit to be in place, and we cannot break a habit. We must replace a habit with another habit. Therefore, they must continue with the maintenance. Healthy ones that they would like to do, that bring a replacement feeling of dopamine and endorphins, the high, the natural high that they're getting out of other areas. It depends on what their why is and what keeps them there. Lapse is just a brief, short resumption or a slip of that dependent behaviour. It could be that they're mixing with the same people, or they found themselves in a social setting, and that's where a lot of that may happen, and they forgot, or they really wanted to be around that and thought just that one moment wouldn't. So that's a lapse or a slip. And then the maintenance is the process of finding the support people, and the support practices. It can be even putting reminders on the fridge. It could be doing a reflection journal, things that prompt and we see around us as well. And then also some of the people around that process around maintenance, or maybe changing, being around some of those people. So what are some reasons? Being tempted, not yet quite got strength around that coping mechanism. Emotional, physical, or mental health, what triggered them. I had a really bad day at work, and I thought, stop it, just gonna do that. And then all of that can lead to justifying why I'm going to do it. And it's not going to make any difference anyway. So this self-talk is really important. That sits in our coping strategy. So we need to be working on those areas and with our clients. Oftentimes, that is as we model that behaviour with our clients and explore that. So there is encouragement and support for progress, letting people know that this is actually quite common. It is hard, and if it's taken years to get there, it can take longer than what we've given it so far to be able to turn that around. It depends completely on that individual's social, emotional, psychological, and their physical well-being. So slipped and supports. So let's have a look at psychological and clinical, reviewing the goals, measuring the goals, celebrating some of those successes, use of change talk, so self-talk. What do we say when we're talking to ourselves? Working with our client on changing the script, a different dialogue, and our motivational thinking, our positive thinking, what lifts you, what brings you down. So as a brief intervention is only brief, the professional, that's us, and you, must be aware of the right channels for further ongoing support. So you must know what's available. So if our client only sees us 1 hour a week, what are they going to do for the other 165 hours that they're awake? Where are they going to go? Who can they talk? Places like online Black Dog, Beyond Blue, because we don't separate alcohol and other drugs from mental health. There's some really good AA meetings as well. They have a 12-step program that's an evidence-based one. It really is quite successful. It's strength-based, it has routine structure systems, and then they will have somebody who will be appointed to shadows and buddy that you can call if you're tempted. So let's have a talk now about those seamless referral pathways and the wraparound supports. So who do we know out there that we can refer our clients to be part of this plan, and our clients can go and access those when they're not around us? And then who are their wraparound supports and what's available in the community for our client? How can we build that into a holistic care plan model? So providing opportunities and greater referrals for support. So the government do fund some drug programs, residential rehab, or they will fund an organisation to do that. Community programs and support groups, so like AOD, AA, Al-Anon, NA, Narcotics Anonymous, psychological interventions, and prescription medication with your GP. So all of these will be part of that support. So you'll need to refer your client to those clinicians or into those services unless you're working in one of them. So your practitioner skills and your role play reflections, research some other sources for referrals. So I want you to look into what's available in your local area. So I live in Queensland, Tarrabala Bunda, which is often referred to as Bundaberg, and they are only now putting in a residential rehabilitation 27 beds and 8-bed clinical detox. So that's actually really significant for regional Queensland. The closest is about a 7-hour drive. And by the time our clients are most vulnerable, often just that can be a big barrier to accessing it, not having the supports in the meantime. There can be some casework. However, often in brief interventions, we are at that point where we need to have some immediate responses. So find out who can your clients go to, who can you refer your clients to who can you engage to be part of this plan, and what is a realistic timeline? We can't overpromise and underdeliver. We have to have realistic expectations. So the best thing is for you to know what's available for our clients and also what's in their local area, and build relationships with those people as well. So have a look around your postcode. If you're going to be a worker in that area, what community services are there? What does the public system have? What does the private health sector have? What supports are there for people of different groups? Might be a minority group where it's a different English as another language. What's available there? What might be another area that we need to consider? Housing and homelessness. We know that the public health system will not work with the mental health side until the AOD side has been worked through, that to increase the capacity for them to be able to do some of that mental health recovery work. Even if mental health is at the root cause, or trauma is at the root cause of why someone has these maladaptive coping skills and using substances or overuse of prescription medication to be able to manage that psych ache that they're dealing with. So documentation about resources and law. So initial triage is your initial intake and assessment, your entry or your exit as they're leaving that program. There's quite a few in the public system. We have a step up and step down, so not quite ready for admission, or if someone is leaving the hospital system, that step down, which is that care moment of 12 weeks or up to 12 weeks before they return back to where they were living, because they're not quite ready to live on their own. However, you as a worker will also identify there's other barriers there. How is the rent being paid in their place while they weren't there or they aren't there? We need to think about what all of those things mean for our clients. So it's a triaging that we do in this space. Triaging around suicide intervention is helpless, hopeless, and alone. If all those three elements are there, that places someone at high risk. It's a triage method that we would use here as well. And then we look at who can we provide in that help stage, what wraparound supports and motivation can we put in place for that hope, and that alone, who is there to support them, and you as a worker can fill that gap. So the triaging means that we're bringing in other supports, but it's also a model that we use to assess the risk of our client. So a referral should include a letter to the GP, and of course part of your assessment will ask you to do something similar. And so that's a summary of your intake and assessment and why you're referring that client over, and what elements would you need to put into that referral letter or a referral email as well. And usually your document, your treatment plan will be attached to an email. Of course, private and confidential, and ensuring that you've secured everything and your client gave you consent to do that. So our motivational interviewing is our ability, our micro skills, so that we can understand what the positives may be for our client, so that we can move them towards that healing, hope and recovery, and the goal to minimize or end that dependency or codependency, because if I don't do that, then I'm going to lose this particular group of friends. So it's strength-based, so we believe we support and validate. We will use a range of questions, so a questionnaire. We'll have a think about the strengths and how we can support those and build on those, and our client actually engaging in that conversation as well. When we are recording matters about our clients, we would, if the client told us something, then we would scribe that as the client stated. The client has presented with, my observations are perhaps, maybe, would consider. we don't make definite statements because that is not a fact. Those things are still being explored. We are still in that discovery phase when we're in that brief intervention. It's only once we have done some comprehensive casework over a period of time can we see a pattern of behaviour and speak to that with some confidence and expertise. So the client may have identified some barriers. You may also identify some potential barriers. Change that has occurred, what triggered this, what changes are they going through, what changes have you already implemented that are working, and what motivated any of that change. So someone may come to us because they've had a personal event and it's triggered their use again. It could be a death in the family, it could be a loss of a job, it could be many things, because there's so many different levels that if somebody is impacted by that, another person might go through that and they are more resilient and agile because it's happened to them at a different stage. But for our client, that may be catastrophic for them. Because it is their experience and their unique response around that. So we need to check our own lens and our own biases, our unconscious biases that may exist there as well. And what is best practice in this space? So we work to industry standards, sector standards, rights meeting diverse needs, accessible, private and confidential, unless, of course, there is a risk to self or others. What are the codes of practice and the standards of those practice? So how do we apply those in our work? So the human rights of our client, the dignity of risk that they can make those choices that impact their lives. So here we have the 5 standards, and we're going to ask you to look at these in your assessment. So what are they, and in that order? So their rights, responsibilities. So you have rights as a worker and you have responsibilities. Our clients have rights and they also have responsibilities. That is working inside those healthy professional boundaries. So we work with our client, who's our primary client, but we may have secondary clients, and that could be the family who will do all the other stuff in the meantime when we're not there. Meeting diverse needs, so that could be developmental, could be age, it could be physical or psychological capacity, could be language, culture. There's so many other diverse reasons why we would adjust our style, and the only way to do that, know that, would be to work with our client and understand what other variations or considerations do I need to put in place. What else might you need? So if we find a great place but they can't get there, or it's a financial hardship, then that isn't a great referral place. But it's between you and your client to work out if that is the best place and they would like to. Then we set our goals on how can we put that in place. What other supports and services might be there to assist in that process? So standard 4 would be working with First Nation people, Aboriginal and Torres Strait Islander people, families and communities. That is also a diversity, and making sure that we make whatever those reasonable adjustments are. It might mean that we bring in a broker or someone from community, from that mob, where they are able to provide support if that is not your area of expertise. It's enough that you consider that this may need to be in place to make sure that we're providing the right type of support plan around our client. And then access to mental health practitioners, because we know that we cannot separate those two things. And then making sure that we go back and review. So if a client says, look, I know you referred me there, but I just didn't even like the worker. Okay, great. So will we practice what that might be like, or can I support you in that? Or would you like us to be looking for another worker? always it's about, well, I don't know, I just felt really uncomfortable. I hate telling my story over and over again. I would like to think that we had asked those intentional interviewing questions beforehand. When we make a plan, is which things would you be comfortable doing and which things would you like our support to be able to do? We need to be very clear what we cannot do in our role as well. And so when I say don't overpromise and underdeliver, we need to let our clients clearly know the scope and boundaries of our role. And we as an employee or a worker for an organisation must work within those. That's part of our legal and our ethical requirement, but it's also part of the protocols that keep us safe in this space. So standard 6, a very individualised case plan. Treatment and support, what does that look like? Your treatment plan, we give you a template to show you what that's like. Transitioning, so that's moving from your support over into greater care. How we integrate our services, so we might do case conferencing or shared case work with other agencies. That's very common in our day, where we're saying, okay, this is the bit that I'm doing, we're having progress, and everybody is looking at that. So that way it's not all on one person and each of us do that area that we're highly skilled in. You may be the lead worker, and then you put all of those different people around your client. Of course, you're person-centered or client-centric means that they are the focus. Everything comes off from that. So quality improvement, which is this working? And if not, let's revisit. And the client will let us know. And so will our stakeholders as well. Communication and information management, storage of securing that, and the sharing, making sure that we have consent and that the consent that we receive from our client was informed consent. And at all times, the client owns their file, their plan. Health promotion and prevention. So if there is something that's helpful for them, that we promote that. And we also do that around our colleagues, our peers as well. Ethical practice and professional development responsibilities, that is your ongoing learning so that you can provide the most current evidence-based practices and standards back to our clients. And then COP is community of practice, which is what you will do with your peers in the workplace. So we might at HADA just say, oh, let's talk role plays, let's talk brief intervention, let's talk AOD, let's talk youth work. We will then hone those skills amongst ourselves. And then, of course, in the sector, in a day-to-day, most of our trainers have lead or program manager or even regional manager roles in the sector, and have quite a lot of staff that they have reporting to them, or they are viewed as an SME, a subject matter expert in an organisation where they will refer people over to. So we try and gather all of that collective wisdom from our team. You will do that also in the workplace. So you might even see someone at work and you go, you know what, I really like how they do that intake, their style. I want to be able to watch them and shadow that. But you can get that externally as well. There's some incredible short interviews and YouTubes that you can watch. Gabor Mate is definitely one of my favourites because he does so much work around trauma, and the connection of trauma and also addiction, attachment theory, and anxiety and mental health. So keep in mind that addiction is a maladaptive, a poor choice coping mechanism for someone who's trying to mask or overcome another problem. So there's another issue going on, which is those coexisting needs. We're working in brief intervention around risk assessment. So some research, look up the Standards of National Practice Standards of Mental Health Workforce 2013. It's an assessment question. Choose 2 standards just for practice and identify their importance in your work role or the industry that you would like, sector you'd like to get into. This will definitely come up in your assessments, not the 2, but being able to go in and look for those 2. So there's your resource. The Standards of National Practice Standards for the Mental Health Workforce 2013. And in wrapping up, I like to work with a framework. This is evidence-based. It is also one that most of the government-funded agencies, there's another one in STAR, but there's several. It's just one of my favourites that I like to work with, the CHIME framework for personal recovery, which is connection. So peer support, social groups, relationships, support from others, and connection to community, hope and optimism, belief in recovery, motivation to change, hope and inspiring, supportive relationships, positive thinking and valuing the effort and progress that people make, and having goals, dreams and aspirations, identity, rebuilding, reinventing, positive sense of identity, and then overcoming the stigma that is attached to a diagnosis or a maladaptive coping mechanism. Putting meaning in a mental health experience, meaningful life and social roles. A lot of people can feel a sense of worth if they do some volunteer work until they're ready to go back to work. If they can restart programs, reintroduction, reinventing, finding new people to mix with. All of these are part of that personal recovery. And then empowerment, which is about agency, taking control and having those decision-making. So the personal responsibility that sits in there, that's your responsibility, your choice, and control over their own life and those decisions. And then focusing upon the strengths as they make those decisions around their personal recovery. So that's the end of our session. So we've done that in 2 bites around session 1 and then 2 and 3 and 4. So quite a big unit, which I've broken down into bite-sized pieces for you. And now I'm going to I want you to take 5 minutes to stretch and hydrate, and I'm going to take you over into some of the assessment area to be familiar with that for this CHCCCS014. Okay, so let's have a look at our written work, our assessments. So for CHCCCS014, provide brief interventions, task 1 of 3. So when you see task 1 of 3, that means that there are 3 different tasks that are asking you to do assessment work. In task 1, which is an online quiz, so first of all, you go into your e-learnings, which is a bit of a practice run if you want to. However, you can go straight over to your assessment work if you want to. Your e-learnings don't count, but they do give you some language and a bit of a practice run before you jump into your assessments. You get 3 attempts at your assessment, and we can open up more for you. But I would like to think that you'd be reaching out if the feedback wasn't landing in a way that you could unpack that and understand it. So read through your questions and your feedback if something does get sent back to you, and get some guidance, and know that you also have your learner support officers who will be able to assist you with any questions that you've got. If it's something that needs a trainer and assessor, then they'll feed that back to our team, and someone on our team will work with you. So there's 17 questions. The first one starts off with, just as an example, Leon is 37 and has been using alcohol and other drugs for approximately 15 years. His health is suffering and is showing signs of liver damage, poor dental health, and reduced cognitive function. So the capacity to be able to think and make those decisions. However, is still reluctant to engage in a recovery process or to consider the interventions which you're suggesting, some of those strategies around the brief interventions. So list 5 reasons why Leon may be reluctant or resistant to change. Now, we just covered that in our slides. So this recording ends up being one of your resources, and then so does your learner's guide as well for this unit. So for every unit, you have a learner's guide with some resources. So we did cover this one, but just go back to you when you first get your resources, watch this. I like to break it down into bite-sized pieces because it's a lot to retain. And I find that usually 40 minutes maximum that you spend in any given time, then move away from it and then jump back in again. But every day I would be looking at this work so that the knowledge stays with you rather than a big block. But you've got your own learning style, whichever way is best for you. So there's 17 questions there. Once you've put in, there's 5 spots there for you to put your response in. Then you see here you can save your answer, and that will take you to the next page and the next question. So let's have a look at some of those. Look, that changes your screen, I'm aware of that. But I just wanted to be able to show you that there's a brief case study, discuss 3 strategies, describe each of the following. Let's have a look of the interventions. What is motivational interviewing? Describe that, and an example of what motivational interviewing. Now you'll find that in your video recording around motivational interviewing, that resource. CBT, cognitive behavior therapy, you'll also find that in your recording. So your assessment is linked to your learner's guide and to this recording and the slides that I put into the recording and the additional resources that are provided for you, which will come to you in brief videos. So save all of those. These are your resources to keep and enjoy being in this topic. Let me just show you another assessment. I'd like to take you over how we assess and mark actually a role play. So just a quick look at task 2 out of 3 tasks. So the first one was the online quiz. Task 1, there's actually 2 role plays, and this is what an assessor looks for with your role play, your practitioner skill. It'll give you a scenario. There'll be instructions on how to be able to do that. So read through those and practice. We also have a toolkit of role plays, lots of ways to get your recording there. If you need some further assistance, of course, come back to your learner support officers. But it's very self-managed and self-paced, your study. If it says you specifically need an assessor to be there with you, then you book that in and we assist you. But if it's something that it says you can do with friends, family, and colleagues, then you can do that in your own time. Just make sure that you watch the resources on what we look for, how to set up your background in a simulated workplace environment. Turn up as if you're ready for work, identify yourself and the unit that you're working on, and the task number. The same way as what you would if you were a worker in the sector as well. So with this one, this is what the assessor sees, an observation checklist when we're marking you. And there's 11 points that we need to capture as we're assessing your skills. So number 1 says, during the role play, I observed the learner demonstrate the following. So motivational interviewing with the person who is contemplating change to discuss and determine issues that are concerns or barriers and the person's stage in the decision to change. So through your questioning, you'll be able to work out, like, is this something that they don't yet see as an issue? And it's okay, you know, you're just really looking at measuring that, and that will be evident in your role play. So it depends on where that client is up to and based on the scenario. And then how do you get to that rather than giving advice, which we don't, but we do that with our motivational interviewing. Let's have a look at some others here. It will change your screen, and I apologise for that, but it's during the role play. So there's 11 things that I need to be able to capture. That you raised awareness of the health issues with the person who is not contemplating change. So you mentioned, perhaps as an example, that you're struggling with your sleep patterns at the moment. Just how are you managing that fatigue? And it has been a while since you've had a really good sleep. Because we know that as part of the health. So that could be a health issue, or it could be that they're struggling, they've got poor health, lots of infections, they could have a reoccurring rash. It could be that they're in a lot of pain with their oral, their dental health as well. So oftentimes our clients will come in with other issues. It might be housing, but we're looking at the underlying matters as well. So what does that mean for us in a brief intervention? Let's deal with what it is that's concerning our clients. So look, we've got a bulk billing GP who works very closely with our clients. Have you got a GP of your own that you go to? Is that something that you would like me to be able to assist with? And when would you be available to do that? They're the kind of supports that we can put in, because it's based on the client's needs. So it's person-centered. So they can present with some issues, depending on the scenario, and we prioritise those to validate and acknowledge that what the client is looking for. But we also can introduce perhaps some others that we would consider. So in this case, both a GP and a dentist could be, for example, two of those. If someone presents and they need to see a GP, I know the GP is going to do some mental health assessment work with maybe a K10, the Kessler 10, asking the questions to see where they sit. That can give them a referral over for free sessions, 6 free sessions with a psychologist. So my mental health side might get looked after and picked up there. That will depend on my referral letter that I send out to the GP. So all of these that we've been talking about in our unit for this one, and our key learnings, they're now linked into how we're going to be working with our client. So I'll just show you that one brief on how we observe, and I want you to read through that material, read it to understand. If you've got questions, then take your questions to lso@haiderinstitute.edu.au, and then if it is a trainer assessor question, they'll bring it back to us, and once you've connected there, knowing that it might take 24 to 48 hours for someone to get back, because like I mentioned in our session together, is that everyone's a sector worker and we're a night college. And so as a night training organisation, some of our trainers only work on certain nights. So we want you to access your learner support officers, who we have a team and they work full-time. And they're there till 7 p.m. at night, which is Haida time, which is Melbourne, where our head office is. And you can book in and get some support. So there's small study groups if you need that. There's that one-on-one support if you need. Sometimes a quick phone call can help clarify things for you. So you can work at your own pace, but you also have quite a lot of support there. But that support is specific to your needs. So we wait for you to reach out and let us know what that might be after you've read through your material and you have that attempt, and know that you can have 3 attempts. But if you want some clarification, we can't tell you what your assessment looks like until you have actually submitted it in the portal. But we can certainly help you if there's some questions. So you would just say, look, to the LSO team, my question is CH from the unit CHCCCS014. And I'm stuck on task 2 in the role play. It says here, and you just want that to be clarified. What does that mean? Where can I find that? If you haven't been able to get clarity around that, we're there to help you. And the LSO team have all of these resources in front of them, so they have a good understanding of what you're asking. They also have access to your portal, as do I, if I'm that person that you're contacting. So please reach out. Because we're definitely here to walk beside you with your studies, and we want you to be able to complete these and feel confident as you step into that space. So we look forward to working with you, and I hope that you enjoyed this unit, the learning about it. It's a very specialised area when we're working in AOD, but it is common. Many of our vulnerable clients have some impact or are impacted by alcohol and other drugs and addictive behaviours. So that's the end of our session, and please reach out. We look forward to working with you.